Hello and welcome to Operating Room Essentials for the Labor and Delivery Nurse. Today we're going to discuss some of the essential parts of performing a general anesthetic in the operating room, because although you are all excellent, amazing, competent nurses when it comes to labor and delivery, unfortunately we're not often in the operating room. When we are, it's usually with a spinal or an epidural. For this, we're going to discuss the specifics of an emergency where we have to use an actual intubation with an endotracheal tube or a general endotracheal anesthetic. Okay? So we'll start with the start. The most vital part is making sure we have vitals the entire time. These patients are often not doing well, or baby's not doing well. So the main thing we're going to talk about is our monitors. We use our standard ASA or American Society of Anesthesiology monitors that are required for pretty much all patients undergoing any surgery. Blood pressure, of course. Blood pressure goes on for obvious reasons, making sure we're monitoring the perfusion pressures to both mother and baby. Blood pressure cuff, and also a pulse oximeter. If possible, on opposite extremities, but for the sake of showing, that's what we're going to do. Now, she's also showing that she's putting these on because that's where we actually need a lot of help from you as the circulator nurse, because in an emergency, I'm over here, and I'm drawing up all the medications that we're going to need. Succinylcholine, Intomidate, epinephrine perhaps, anything that's going to help keep her alive. So as I'm doing this, as quickly and as efficiently as we get the monitors on is always appreciated and actually necessary. Blood pressure cuff, pulse oximeter should go on first. That way we're cycling that, having that ready to go so we know if she's starting to crash or not. Next we have our EKGs. EKG, what's important about that is the placement. Right, so it was developed by a Dutch doctor named Entevin, who developed the triangle. That's what we look at. We look for leads 2 and V5 most importantly. So it is important where you place them. You can't just place them anywhere on the chest like you see people do often, especially not in an emergency. So the first one goes on the right side, and remember that by white on the right. The white one goes on the right side, on the right pec, if possible. Next, for our left, this is a 3-lead EKG. On the left side, we're going to place the black lead on the left chest or left pec area. And then finally the red. Red goes, it's supposed to go if you take your anterior axillary line or your armpit and your 5th intercostal space, which is about, let's say, about 1 inch below the nipple and about 1 inch over laterally as well. So those are your 1, 2, 3 leads. Some easy ways to remember that, as we said, white on the right, and then smoke above fire. So the black is above the red. So in a bind, you don't have to worry about it. White on the right, smoke above fire. As close to this area as possible is preferred, because that's what we're looking for, is that left ventricle, because it's using the most oxygen. Of course, a lot of times during pregnancy, the unique challenge is a large breast. Don't be afraid to move it out of the way. It's an emergency, she won't mind, we'll have to do it as close as possible to that area. But a lot of times you'll see people just put them right here. That doesn't really tell us that much. So we've got blood pressure, we've got a pulse ox, we've got EKGs, we've monitors here, we're ready to go. The next part becomes one of our most important things, which is securing the airway and getting her to sleep. However, before we get to that, I do want to mention a few more things. Since we're in an emergency, we may need some extra monitors, not just the standard. Those include an arterial line and a central venous catheter. Those can be found in our ORs. They're not always put together because they expire, but we have them over in this location here. So what we look for, the central line will be quite easy to find. It's a large package like this. And then arterial line is going to have a fluid bag with the hookup for that, and the pressure bag, and of course the arterial line monitor as well. So we won't always have these on every case, usually only if the patient is crashing, perhaps in a massive hemorrhage or need the protocol for a hemorrhage. But it's good to know where they are in case I'm asking for them, we need to set them up. Another thing that may be necessary is an ultrasound, because often if a patient is having trouble maintaining their blood pressures to the point that we need an arterial line or central catheter, it's difficult to feel a pulse or palpate the carotid artery. So the ultrasound helps us locate the radial artery or the right internal jugular, left internal jugular vein for those. On top of that, since we're talking about extra monitors or monitors in case of problems, is of course the crash cart or the code blue cart. We should all be familiar with where that is outside in this location. It's checked regularly for expiration of the drugs, etc. So, and the good news is we also have most of that right here. This almost functions as a crash cart on its own. But it's good to know where that is. And the other thing that's good to know about, and I know this one a lot of people don't know, is the malignant hyperthermia part, because that doesn't come up a lot on the labor and delivery floor. because we don't use triggering agents. What are triggering agents for malignant hyperthermia? Exactly the things we're going to use in this situation, like succinylcholine, right? It's a paralytic. It's what we're going to use to quickly paralyze so that I can intubate and we have the patient stop breathing, relax the abdominal muscles. Succinylcholine triggers malignant hyperthermia. We don't need to get into exactly why that works. It has to do with calcium and rigidity and release of carbon dioxide, but the point is we try to avoid it or be ready for it if it happens, if it's unavoidable. So malignant hyperthermia card is important. Succinylcholine and your inhalational anesthetics, which is our gases. All of those unfortunately trigger it. And some of these patients are young, otherwise healthy, and have never had surgery in the past, so they have no idea if they have a history of it. It is rare, but they may have never had a surgery before, so we wouldn't know until they present here. So crash cart, malignant hyperthermia cart, arterial lines, central lines, those are all the extra steps we might need if we start going down a hemorrhage or a problematic path.
And that malignant hyperthermia cart can be found in OR3 in the anteroom, and it's labeled.
OR3 anteroom, good for us to know as well. Okay, so we've got monitors. We've got our monitors for worsening situations ready to go. I'm getting ready now to go to sleep, to put her, not me, to put her to sleep and to get ready to intubate, right? We're gonna do this quickly. Sometimes it's the splash and cut, as we say, but we still need her secured. So a lot of times what I'll do is I'll be ready to communicate with the OB that as soon as the airway is secured, she can cut, she or he can cut. So what's important in this is a few things. One is gonna be proper handling of the endotracheal tube, and the other is securing our airway with what's called the Selleck maneuver or cricoid pressure, okay? So what I would ask in this situation is I'm getting ready to go to sleep, and literally as I'm starting to push the induction agent, the etomidate or the propofol, I'm gonna ask our nurse to please provide cricoid pressure. Now, what this looks like, and you can zoom in on this and I'll also show you a photo. Everybody can feel their thyroid cartilage, that's called the Adam's apple, more prominent in a man, of course, but you can still feel yours as a female. If you slide your finger down, you feel a slight depression right there. That's a membrane. And right between that membrane, the thyroid cartilage, and that membrane right below it is your cricoid cartilage. The cricoid cartilage, I'll show a little better picture there so it makes sense. Right below your large thyroid cartilage is your cricoid cartilage. The reason it's important, that's the only full ring in the trachea, in the airway. So we use that by compressing that cricoid cartilage, we can compress the esophagus. That way, when we paralyze the patient, anything that's in the stomach won't come back up and then unfortunately get into the lungs. That's the concern. We avoid what's called an aspiration pneumonitis. So that's the look there, right? A little more clear. You can see here how she's already turning red because we've all been finding her cricoids. But the idea is we'll start providing a little gentle pressure as I go to sleep, and then I'll ask her for a full pressure. It's hard, it's a little subjective to describe that exact amount of pressure. I'll let you know if I can see, because fortunately this also helps us bring the airway into view, bring the vocal cords into view for the endotracheal tube. So I'll be, of course, communicating with you, or the anesthesiologist will, to let you know the pressure. But the idea is that if you take your fingers and press on your nose and push, when it starts to get a little uncomfortable, that's about the pressure that you would also apply here to the cricoid. So the idea is to take your thumb and your forefinger or your pointer finger to then you'll feel the thyroid first, move your way down, you'll feel that cricoid ring and provide that pressure as we spoke about. So that is the location there. A little more difficult on a female, and now you'll be able to see it on her. Right. Now as she pushes that pressure, I'll then start getting her to go to sleep. And once she's asleep, I will have handed you this endotracheal tube as well. Now the important thing with that endotracheal tube, and a lot of people forget this, is intubation in a pregnant woman is a little more problematic than the non-pregnant, obviously. They tend to be more swollen. There's, of course, extra weight gain usually, and they're more friable. So anytime things are touched, they tend to bleed. So it's when the tip of this laryngoscope touches things, they'll tend to bleed. So it's important for the anesthesiologist to never take their eyes off the airway once they've located it. So she's providing cricoid pressure, I go in to intubate, and I see my vocal cords. The last thing I want to do is come up and ask for you like this. Instead, what I'm going to ask for is, may I have the tube? Then handing it is important. You see how she gave it to me. She gave it to me the same way that I'm going to put it into the airway. A lot of times people will just hand it to me like this. That doesn't help, or hand it to me still in the bag. You can take it out. It's not sterile. It's going only into the throat. It's not a sterile device. So you can hand it to me like this, exactly as I'm gonna put it in. I'll place it. Then we continue to hold cricoid pressure because the airway is not secure yet. We'll hold cricoid pressure. I'll come back up and I will inflate the balloon, or I'll ask you to, one or the other, we'll help each other with that. And once the balloon's inflated, I'll come over here to my machine, give a couple puffs on the bag, make sure we have carbon dioxide return, which means we're in the correct, we're not in the esophagus, we're in the trachea. And then we know the airway is secure as well. At that point, we can release the cricoid pressure, and then we'll tell the OBGYN, go ahead, cut, you can take over at that point. A few things with that is the cricoid pressure not only helps us intubate, it stops only passive vomiting. Sometimes we give the suction of choline, those contents can come back up because all pregnant women are considered full stomachs. Even if they haven't eaten or drinking anything, due to the location of the baby and the slowing of the gastric emptying, they're considered a full stomach at all times. So it avoids passive vomiting. However, if they actively vomit, we have to actually release it to avoid damage to the esophagus. Hopefully that's a bridge we don't have to cross. If we do, we'll discuss that. But active vomiting, you let go and we'll suction. It's only to avoid passive vomiting. Once the airway is secure, we should be able to cut. And then the other point in this is we've talked about it here. It's actually been a pretty quick discussion, but things are going to move even faster in a real situation. Things get hectic. We don't want it to be hectic, we just need it to be efficient. But about 2 to 3 minutes is about the timing that we're looking at here to have on our standard monitors, to get the medications drawn up, to administer the medications with the cricoid pressure, intubate, and then make incision. Okay? Thank you very much.
Thank you, Dr. Bates.